Chapter 13. Right now, the EMS education standard competencies for this module. Pharmacology applies to patient assessment and management. Fundamental knowledge of the medications carried by advanced emergency medical technicians that may be administered to a patient during an emergency. So it basically covers the fundamentals for the medications that you will use in the field as an AEMT. We will look at medication administration, routes of administration, self-administered medication, peer administered, assist/administer medication to a patient. So as an EMT, you can self-administer, you can do peer administration of medication, and you can assist or administer medication to a patient based on their presentation. You need to be familiar with a few emergency medications, and the information that you need to be familiar with will be the names, effects, indication, route of administration, dosages for the medication administered. You need to be familiar with the action, contraindication, complications, side effects, interactions. Introduction. Important to understand how a medication will affect the body. So you must be familiar with the mechanism of action, which is what the medication does to the body, indication, when to use the medication, contraindication, when not to, routes of administration, the various routes that you will give the medication, dose, this is the amount of the medication required to get the desired effect, adverse reactions, these are complications that can occur from giving a particular medication, what to do in the event of an adverse reaction. So if there is an adverse reaction, you must know what to do to reverse it. The first rule of medicine, first do no harm. So that's fundamental. Your objective is to do no harm to the patient or cause any further harm to the patient. Ensure that a particular medication is clearly indicated to treat the patient's condition. Intravenous IV therapy is one of the most invasive procedures an AEMT learns. A medical problem may alter the established balance among the systems of the body. Basic math for pharmacology is important to calculate the appropriate medication dose. So we need to be familiar with drug calculation. And there are various formulas used in drug calculation. Once you learn the basics, you will apply those. Drug doses and flow rate calculations are common areas of confusion. We will cover that over time. Medication administration. Medication administration is governed by local protocols and online medical direction. Most EMS services carry drug boxes. Standing orders are a form of offline medical control. Some EMS system require AEMTs to contact medical directors before performing certain procedures. So whichever system you're working in, if you're required to give any medication, there must be clear protocols. You must have proper medical direction, or it must be within your standing order, clearly defined within your standing order. Now, it's important to confirm the 10 rights of medication administration. So for AEMTs, it's not 6 anymore, it's 10. And the 10 rights include the right patient, right medication, right dose, route, time, right documentation and reporting. Your assessment must be correct. The patient has a right to refuse, and your evaluation must be appropriate, and patient education is necessary. Procedure for administering any medication. First, obtain an order from medical control. Know when and when not to administer medication. So again, you must know when the medication should be given, when it should not be given, the type of effects that the medication will have when given to the patient, meaning the desired effect. You should know what are the side effects of the medication being given, and you must be familiar with the appropriate dose, and if necessary, you should know how to calculate that dose if required. Make sure medical control understands the situation. Decision should consider patient's age, weight, clinical status, allergy history, concomitant medical problems, other drugs he or she may be taking that can interact with the medication that you need to give the patient. Make sure you understand physician's order, inquire about allergies, verify the proper medication and prescription, read the drug label at least 3 times. So when you get an order, when you take up the drug box, confirm the information on the medication. So that's the first read. When you pull up the medication, you're gonna confirm again. Just before you give the medication, you confirm again, so 3 times. Check expiration date and condition of the medication, verify the form, dose, and route of the medication. Dispose of any syringes and needles safely. Monitor the patient for possible adverse side effects. And usually adverse side effects will develop in the first 30 minutes of administering the medication. Document your actions and the patient's response on the patient care report. Specific medications AEMT can administer. So this slide is very important. So everything on this slide you need to be familiar with. So you must know the indication, contraindication, therapeutic effect, adverse effect, dose, route, right? All of that must be known for all of the medication on this slide. So these are the medications that as an EMT you can administer or help the patient self-administer. Oxygen, oral glucose, glucagon, 50% dextrose, and 50% dextrose is no longer administered in the pre-hospital setting. It's actually 10% dextrose. IV fluids, epinephrine, metered-dose, MDI, medications, nebulized medications, nitroglycerin, nitrous oxide, naloxone, and aspirin. Nitrous oxide is for pain, and that's in a first world system. In Jamaica, you'll see Voltaren being given a lot for pain. AEMT may only administer these medications when allowed by local protocol or a licensed physician. Now, let's review the basic cell physiology, and these are things you should already know at this stage. A human cell can exist only in a special balanced environment. Cells are enclosed by cell membrane. You have the phospholipid bilayer, which is often referred to as the fatty layer of the cell. Important barrier to fluid movement and acid-base balance. Electrolytes. We went through this when we covered pathophysiology. Atoms carry charges, which can be positive or negative. Two or more atoms bond together to form a molecule. An inorganic molecule, which is a molecule that doesn't have a carbon atom as a part of it, is what we would call an electrolyte. So an inorganic molecule is a molecule that doesn't have carbon atoms, but when it dissociates in water, it gives off an electrical charge. That's an electrolyte. Water in the body helps to stabilize electrolyte charges. Still on electrolytes, they are used in metabolic functions. You have cation or cation electrolyte, which with an overall positive charge. You have anion or anion electrolytes, which is a negative charged electrolytes. Starting with sodium. Sodium is the principal extracellular cation or cation needed to regulate distribution of water throughout the body. Again, things that we went through in pathophysiology. Anywhere sodium goes in the body, water will follow it. The sodium-potassium pump is helped by the presence of insulin and epinephrine. Hypokalemia is low potassium, and when there is low potassium levels in the blood, it will cause a decrease in skeletal muscle function. It will cause issues in the GI system, and it alters the cardiac function, and it will cause overstimulation of nerve cells. So sodium is higher in its concentration outside of the cell. Potassium is higher in its concentration inside of the cell, but there must be a certain amount of potassium in the blood, and there must be a certain amount of sodium in the cell. So there has to be a balance. Hyperkalemia, high potassium, if there is a high potassium levels in the blood, that means there is not enough potassium inside of the cell. When that occurs, it causes hyperstimulation of neural cell transmission, which will cause the patient to go into cardiac arrest. Calcium is a principal cation or cation needed for bone growth. Chloride regulates the pH of the stomach, and chloride is an anion. Phosphorus is an important component in the formation of adenosine triphosphate, which is what is needed for the cells to create energy. And phosphorus is also an anion or anion. These are things we covered in pathophysiology, so you can refer back to that chapter or video which goes into more detail. Body fluid composition. Fluids found in the body are composed of dissolved elements and water. A solution is a mixture of two things. Within a solution, you will have a solvent and you will have solute. You need to know the difference between the two. So a solvent is a fluid that does the dissolving. The solute is the particles, the dissolved particles contained in the solvent. So solvent is the water, solute is the particles. Ensure that you know the difference. Fluid and electrolyte movement. Balance across a cell membrane has two components: balance of compounds on either side of the cell membrane and balance of charges on either side of the cell membrane. Excuse me. All right, I'm back. So there must be a balance of compounds on either side of the cell, and there must be a balance of charges. Materials flow from area of higher concentration to lower concentration, and this establishes what we would call a concentration gradient. And once there is movement from a higher concentration to a lower concentration, that's diffusion. So diffusion, compounds or charges concentrated on one side of the cell membrane will move across to an area of lower concentration. That's diffusion. Filtration is a type of diffusion used by the kidneys to clean blood. Water carries dissolved compounds across cell membranes of tubules of the kidneys. Active transport. Now, active transport is a method used to move compounds to create or maintain an imbalance of charges. What does that mean? So first of all, it's active. If you see the term active, it means that some type of energy reaction is required. So there is some type of energy reaction needed to create this movement. So that's one. Two, it maintains an imbalance of charges. So that means that it moves solutes. So it moves solutes or molecules against their concentration gradient. So active transport is going to move solutes from where there is a low concentration to where there is a high concentration using some type of energy. So the solutes are moving against their concentration gradient. It's the opposite of diffusion. And that's how the sodium-potassium pump works. So sodium is actively being pumped outside of the cell, and potassium is actively being pumped inside of the cell. So sodium is moving from where there is a low concentration to where there is a high concentration. When the cell needs to depolarize, an energy is required, and the energy changes the shape or an area of the cell, so that sodium can now flow from where there is high concentration to low concentration, and potassium will do the same. That's when the cell needs to be depolarized. But outside of that, it's active transport. So again, active transport means that energy, some type of energy needs to be created for that transport to occur, and the solutes or molecules or electrolytes are moving against their concentration gradient. So they are moving from where there is a low concentration to where there is a high concentration. That's the opposite of diffusion. Now, osmosis is a movement of water. Water is a solvent, remember that. Osmosis, movement of water across a cell membrane. It occurs when there are different concentrations on each side of the membrane. So osmosis is the movement of water where from where there is a low solute concentration to where there is a high solute concentration. Tonicity of a solution. So tonicity of a solution, effects of osmotic pressure on a cell. So you have hypertonic, you have isotonic, and you have hypotonic. Hypertonic has a high solute concentration in the extracellular fluid. So what that means is the fluid that the cell is in, it has a higher concentration of solutes than what is inside of the cell. So that fluid is going to pull water from the cell and the cell shrinks. That's a hypertonic solution. An isotonic solution is a solution in which the solute concentration in the fluid outside of the cell is the same as the solute concentration inside of the cell. So water can move in and out of the cell without changing the shape of the cell. Hypotonic solution is a solution in which the cell solute concentration is the cell solute concentration is greater than the solutes in the fluid, than the concentration of solutes in the fluid. So the cell will now pull water in and the cell can swell and burst. That's a hypotonic solution. Very important slide. Now, fluid compartments. Water can be intracellular, which is inside the cell, and majority of the water is inside of the cell. It can also be extracellular, which is outside of the cell. An extracellular fluid is divided into interstitial fluid and intravascular fluid. Homeostatic control mechanisms ensure balance is restored. Body's circulatory or vascular system function as a fluid highway. Fluid compartments in the human body: intravascular, that's extracellular; interstitial, that's extracellular as well; and intracellular. Majority of the fluid is intracellular. Extracellular compartments contains intravascular fluid, which surrounds the blood cells, and interstitial fluid, which is outside the vascular system and between the surrounding cells. Perfusion occurs in the capillaries within the circulatory system. Intracellular fluid, or ICF, within all cells of the body. Large proteins within the cell can draw fluid into the cell. Again, majority of the fluid inside of the body is found within the cells. And this diagram shows where the fluid is. So it shows you where interstitial fluid is, it shows you where intracellular fluid is, and it shows you where intravascular fluid is. And that is very clearly defined. So intravascular is a fluid within the blood vessels. Interstitial is a fluid between the cells, and intracellular is the fluid within the cells. And I believe your textbook break it down in a percentage. Ensure that you know your percentage numbers. Water surrounds all cells. It plays part in cellular metabolism and maintenance of homeostasis. Body adjusts to changes in balance between ICF and ECF ICF, intracellular fluid, ECF, extracellular fluid, by retaining or eliminating water. Feedback systems create appropriate response to maintain the internal environment. Dehydration. This is depletion of body's total systemic fluid volume. Signs and symptoms include changes in level of consciousness, orthostatic hypotension or positional hypotension, dry mucous membranes, tachycardia, poor skin turgor, flush, dry skin, decreased urine output. Causes include diarrhea, vomiting, hemorrhage, insufficient fluid intake, and infection. Very important point to note. When a person has an infection, they can become severely dehydrated. Keep that in mind for your pediatric population. Overhydration, the result of total systemic fluid volume increase in the body. Signs and symptoms include shortness of breath, puffy eyelids, edema, polyuria, moist crackles, weight gain. IV fluid composition. Compounds and ions dissolve in the solution or are identical to ones found in the body. Each solution is a concentration of solute and solvent. Solute is the dissolved particles, solvent is the fluid. Sodium is used as a benchmark to calculate a solution's tonicity. Common IV fluids AEMTs administered is normal saline or 0.9% sodium chloride. Crystalloid solutions. Dissolve crystals in water. Best choice for the pre-hospital care of injured patients with body fluid loss. It is increasing blood pressure with IV solutions. It dilutes remaining blood volume, and it may increase internal bleeding by interfering with hemostasis. So this is an important point. So crystalloid solution is going to be the most common solutions that you use as an AEMT. However, it's very important that you are properly guided when giving these fluids, because if we increase the blood pressure too much for patients, especially patients with internal bleeding, it can dilute the blood volume, or as I would say, can thin out the blood, and it can interfere with clotting factors, which a patient is going to need if they go into surgery. So fluid overload, you need to be mindful of that in the field. Colloid solutions. Colloid solutions contain molecules too large to pass out of the capillary membranes. They have a very high osmolarity, could cause dramatic fluid shifts and place the patient in danger if not administered in a controlled setting. So crystalloid solution are isotonic. Colloid solutions would be hypertonic. So these are fluids that can pull fluid out of the cell. Not going to see that much in the pre-hospital setting. Isotonic solution, same osmolarity as serum and other body fluids, expand contents of the intravascular compartment without shifting fluid to or from other compartments. Lactated Ringer's solution is generally used in the field for patients who have lost large amounts of blood. So the most common isotonic solutions will be normal saline, lactated Ringer's, 5% dextrose in water. So these are isotonic solutions. The 5% dextrose in water is only isotonic in the bag. Once it goes into the body, it becomes a hypotonic solution because the dextrose is quickly absorbed by the cell and water will follow it. So it becomes a hypotonic solution. But once it's in the bag, it's isotonic. Normal saline has sodium chloride. Lactated ringers has the same sodium chloride, but it has other electrolytes in it, and it also has lactate. Now, if lactated ringers is given to a patient who has good liver function, then their liver can convert the lactate to bicarbonate, which can help to reduce acidosis in the body. So lactated ringers, in theory, might be beneficial for a patient in metabolic acidosis. There is no research data to suggest that using lactated ringers is better than normal saline. So either can be used in the pre-hospital setting. I haven't seen any data that suggests one is better than the other. They are both isotonic. Hypotonic solutions lower the concentration of, hypotonic solution has a lower concentration of sodium than the cell. Hydrate cells while depleting vascular compartment. Dangerous because can cause a sudden fluid shift from the intravascular space to the cell. Again, this will not be fluids that you will use in the field as an AEMT. The fluids that you will use is going to be isotonic. But there are situations where hypotonic fluids can be used and hypertonic fluids can be used. Hypertonic solution has more ionic concentration than serum. It helps stabilize blood pressure, it increases urine output, and reduce edema. Rarely used in the pre-hospital setting. Now let's look at techniques and administration. Keep IV equipment sterile. Prepare all equipment before you attempt to start an IV line. So as an AEMT, you should know how to initiate IV access and intraosseous access. And we will start an IV access for the purpose of keeping a vein from collapsing, which is either going to be 1 drop per second or 2 drops per second. We will start an IV access to administer medication, or we will start an IV access to do fluid resuscitation. So the IV equipment needs to be kept sterile. Prepare all equipment before you attempt to start an IV line. And you will need your IV fluid, your administration set. You might need a stop lock, venous constricting band, the specific IV catheter that you think can fit that patient, something to secure the IV site, tape. Choosing an IV solution. Identify situation and needs of the patient. Is the patient condition critical or stable? Does the patient need fluid replacement? IV solution bags come in different fluid volumes. So you can have 50 mils, you can have 100 mils, you can have 150, 200, 500, 1000. Now, usually bags within the range of 500 to 1000 mils are used for fluid resuscitation. The bags below 500 mils are usually used for medication infusion. Choosing administration set. Administration set move fluid from IV bag into the patient's vascular system. Each IV administration set has a piercing spike protected by a plastic cover. You have different types of drip sets. So you have your micro drip set, macro drip set, and blood sets. The micro drip set is more for controlled administration or drug infusions. The macro drip set is usually for fluid resuscitation when a large amount of fluid needs to be administered. So macro is going to be more for your shock patients. Micro is more for controlled administration and drug infusion. So the micro is 60 drops per mil, and as it states, it means that if you're using a micro drip set, it takes 60 drops from that set to give you 1 mil. Macro drip set can be 10, 15, or 20 drops per mil, and as it states, it means it takes 10 to 15 or 20 drops of fluid from that drip set to give you 1 mil. To know how many seconds that would be, you simply take that number and divide it into. You take the number for the drip set and you have 60 seconds, you divide the 60 seconds by the drip set, and it will give you how many seconds it takes. Now, blood sets are designed to facilitate rapid fluid replacement by manual infusion of multiple IV bags. And as it states, blood sets are used really for blood infusion. Selecting a vein. Locate the vein section with the straightest appearance. So you want a vein that's straight, you want a vein that's springy, you don't want a vein that has too many valves, and it should be able to fit the desired catheter that you want to use for the patient. So choose a vein that has a firm round appearance or is springy when palpated. Avoid areas where the vein crosses over a joint that can be dangerous. Avoid any extremity that shows signs of trauma, injury, infection, or edema. Avoid any extremity with a dialysis fistula. Avoid any extremity on the same side as a prior mastectomy or lymph node dissection surgery. For critical patient, always start at the antecubital fossa or higher. Right? So we want to go more up the arm for critical patients. Stabilize the wrist veins by flexing the wrist and pulling the skin taut over the vein. IV access in the hand is painful. If the patient is not critical, you can start there and gradually move up. Just keep in mind that IV access in that area is going to be painful for the patient. Now, choosing a catheter. You have your over the needle catheter and your butterfly catheters, which are most common. These are what you will see most being used in the hospital or pre-hospital setting. I have different types depending on the manufacturer. Over the needle catheters are sized by their diameter, referred to as the gauge. Over the needle catheters can be used for all adults and most children for long-term IV therapy. Inserting the IV catheter. No matter what technique you use, keep the beveled side of the catheter up when inserting the needle in a vein. Maintain adequate traction on the vein during cannulation. Be careful how you apply traction on the vein because you don't want the vein to flatten out. So sometimes if you put too much traction, it can cause the vein to flatten out, and you don't want that. Sometimes you may not need a tourniquet. Why am I saying tourniquet? Sometimes you may not need a venous constricting band if the patient has nice visible veins. You can attempt the access without the venous constricting band. So when they have nice veins and you put on that venous constricting band, it can create too much pressure inside of the vein, and when you put the needle in, it just ruptures. You can you can elevate the limb to create pressure on valves to open them. That's when you don't have a choice, because sometimes you might not have a choice. You may have to go with a vein that has a valve. A technique you can use is to elevate the extremity to create back pressure on the valve, and that can help it to open. You can use iodine to show veins in persons with dark skin or dark complexion. In the field, I will not attempt more than 2 access generally for a critical patient. For a MI patient, I might attempt 3, but generally you don't want to go more than 2 attempts in the field. So if you miss it after 2 attempts, you should probably let someone else try. Apply a constricting band over the site you have chosen. Prep the insertion site. Advance the catheter through the skin until the vein is pierced, and you will feel when it gives, and you will see flashback in the chamber. If the person's blood volume is too depleted, you might not see much flashback. Once you see flashback, lower the angle of the IV catheter, advance the catheter while removing the needle. Never reinsert the needle. So once you start to pull the needle out, do not reinsert it. You can shear the tip of the catheter and create an embolus. Drawing blood. Now, as an AEMT, apart from passing an IV catheter into the vein to keep the vein open or give medication or for fluid resuscitation purposes, you may have to do blood draws as well. So drawing blood. If blood is drawn, it must be drawn before any fluids or medications are administered. So if you're required to collect blood before you attach your IV line, get your blood. Follow local protocols for the types of blood tubes to draw, and each facility have their own order and colors. Right? You have red blood gives life, red blood gives life, red, blue, green, lavender. Where I currently work part-time, we do purple, red, and if necessary, gray. So it depends on where you're working and what type of test is required. Now, the ideal method for drawing blood is to use a vacutainer. Right? Vacutainer you're going to use a Vacutainer approach, but I can't remember the name of this plastic container. But that's the ideal approach. You can use a syringe and draw the blood directly. And usually we will go for a syringe when it's a difficult stick for that person. But usually the device that you see here, this plastic device, you'll have a needle attached to it, and you insert the needle into the vein. You don't have to go too deeply, you just need to enter the vein and you'll feel it give. Keep your hand steady, then put the blood tube into the Vacutainer and squeeze it, and it will naturally fill with blood. Just like well, you can advance a little, not too much, because you don't want to go through the vein. So if you enter and you put in your Vacutainer, don't shift the needle around. So don't shift the needle from left to right. You can advance a little. If you're still not getting any blood, then you pull that out. You have missed. Securing the line. Tape the area so the catheter and tubing are securely anchored. Avoid any circumferential taping around any extremity. Changing an IV bag. Now, steps for changing an IV fluid bag. Once you have an IV fluid bag on your patient, do not wait for it to be completely empty before you change it. So ensure that there is some amount of fluid left in the bag and the line, because we don't want air bubbles starting to form in the line, and we don't want clots to start forming at the IV site either. So steps for changing an IV fluid bag: stop flow of fluid from the depleted bag, prepare and inspect the new IV bag, remove the piercing spike from the depleted bag and insert it into the port on the new bag. Ensure the drip chamber is appropriately filled, open the roller clamp and adjust the fluid rate accordingly. Discontinuing the IV line. Shut off the flow from the line with the roller clamp. Gently peel the tape back towards the IV line. Stabilize the catheter while you loosen all remaining tape. Gently pull the catheter and IV line. So don't disconnect the IV line from the catheter. Pull everything out connected and ensure that you're holding pressure with a gauze when doing that. Alternative IV sites and techniques: a saline lock. The saline lock just maintains the IV site. It keeps it open. That's the purpose of a saline lock. So it has some fluid inside of it. Saline locks maintain an active IV site without having to run fluids through the vein. This is when you just want to have a site accessible to give a medication. Attached to an end of an IV catheter and filled with approximately 2 mils of normal saline. So we want an IV access to give a medication. We don't need to give them fluid. We establish the IV access and attach the saline lock to it. You can also flush the saline lock when you're ready. So before and after giving medications within an IV site, you need to flush it with saline. Never give a medication and you have not flushed the IV site before or after. That can kill a patient. You don't know what medication was given prior to you giving whatever, right? Or you may have given a medication prior and the medication that you're going to give now can react with the previous one, and sometimes there's residue from the previous medication remaining, and that can cause crystallization. So you have to be careful of that. So again, before and after giving a medication through an IV line, flush the line with saline solution. And up to 10 mils of saline solution is acceptable. For certain medication, you may be required to give more than just 10 mils to flush. You will be guided by protocols. External jugular IV lines provide venous access through the external jugular veins of the neck. Tamponade vein by placing a finger on the vein just above the clavicle, causing the vein to fill. Troubleshooting IV therapy. Perform these checks after completing IV administration and recheck if there is a flow problem. So check your IV fluid, check your administration set, check the height of your IV bag, check the type of catheter used, check your constricting band. Possible complications of IV therapy. Local IV site reactions. Infiltration. So let's look at some localized issues. Infiltration. Escape of fluid into surrounding tissue. Possible cause. The IV line has passed completely through the vein and out the other side. Catheter was started at an angle that is too shallow and has only entered the fascia surrounding the vein. That's infiltration. Signs of infiltration, signs and symptoms include edema at the catheter site, continued IV flow after occlusion of the vein above the insertion point, tightness and pain around the IV site. Thrombophlebitis. Thrombophlebitis is inflammation of the vein. Symptoms that you need to look for: fever, tenderness, red streaking up the associated vein. And the common cause is going to be non-sterile technique. So a non-sterile technique was used to establish the IV access, and it results in that inflammation. That's the most common cause. So common cause include localized irritation and infection from non-sterile equipment, prolonged IV therapy, irritating IV solutions, too rapid infusions. These things can lead to thrombophlebitis. Occlusion. This is physical blockage of a vein or catheter, which causes decreasing drip rate or the presence of blood in the IV tubing. And this would be the first sign that you look for. So there's going to be a decreasing drip rate or the presence of blood in the IV tubing. Common causes include the positional IV site, proximity to a valve, patient movement, IV bag nears empty, and blood pressure overcomes the flow and backs up in the line. To determine whether an IV line should be re-established, use a syringe filled with saline to add pressure to the line. And it's usually going to be a 10 ml syringe with saline solution. Gently apply pressure to the plunger to disrupt occlusion and re-establish flow. If you can't re-establish flow, then you're gonna have to start a new IV access. Hematoma. This is the accumulation of blood in the tissues surrounding an IV site. Results from vein perforation or improper catheter removal that allows blood to accumulate in the surrounding tissues. Nerve, tendon, or ligament damage. Results from improper identification of anatomic structures around the IV site. Symptoms include there's going to be sudden severe pain, there's going to be numbness in the extremity. You can have arterial puncture. This is cannulation of an artery. If this occurs, immediately stop IV administration and apply direct pressure to the site with your gauze bandage until bleeding is controlled. Now let's look at systemic complications. We just finished looking at localized complications. Let's look at the systemic issues now. Systemic complications can develop from reactions or complications associated with IV insertion. Allergic reaction, that's the first one. Allergic reactions often minor, but anaphylaxis is possible, related to an individual's unexpected sensitivity to medication, must be treated aggressively. Common signs and symptoms of allergic reaction: itching, difficulty breathing, swelling of the face and hands, urticaria, bronchospasm, anaphylaxis, wheezing. This occurs, discontinue IV administration and remove the solution. Ear embolus, ear bubbles that blocks blood flow. This will occur when the line is improperly prepared. So ear bubbles that blocks blood flow can lead to an ear embolus. Properly flushing an IV line will help eliminate any potential of introducing air into a patient. Replace empty IV bags with full ones. Signs and symptoms include cyanosis, signs and symptoms of shock, loss of consciousness, respiratory arrest. Catheter shear occurs when part of the catheter is pinched against a needle and the needle slices through the catheter, creating a free-floating segment. Blockage of other vessels may result in a myocardial infarction, stroke, or other problems. Treatment involves surgical removal of the sheared tip. Circulatory overload. Common cause is failure to adjust drip rate after flushing an IV line immediately after insertion. Patient presentation include difficulty breathing, distended neck veins, an increased blood pressure, slow IV rate to keep the vein open and raise the patient's head to ease respiratory distress. Administer high flow oxygen and monitor vital signs and breathing adequacy. Vasovagal reactions. Some patients have anxiety concerning needles or the sight of blood. Signs include anxiety, diaphoresis, nausea, syncopal episodes. Place the patient in the position dictated by protocol for shock management. Now, pediatric IV considerations. Catheters available in various sizes. Butterfly catheters are ideal for pediatric patients. Scalp veins are best used in young infants. Now you have the 14 gauge, 16, 18, 20, 22, 24. Rarely you will see a 14 gauge used as IV access in the field. So from 20 to 14, you'll see used mostly for adults. Rarely you will see 14 being used in the field. 14 is the size that would be used for needle decompression. 16 is ideal for fluid resuscitation, but you need a decent size vein to fit a 16 gauge catheter. So if you are thinking about putting in a 16 gauge, but patient's vein doesn't look like it can fit a 16, then you go to a 18. But ideally, 16 is for fluid resuscitation, but it's very difficult to put in a 16 gauge catheter. 18 is the IV catheter for medication administration. So if you're thinking about giving meds, that's a good one to use. 20 is for your geriatric population. That's the one that you will see used commonly in your geriatric population. A 20 can also be used for a large size pediatric patient. Now, anything below 20 is going to be for your pediatric population. So anything below 20 is for the pediatric population. So note that the smaller the number, the larger the IV catheter is. The greater the number, the smaller the IV catheter is. So just keep that in mind. IV location. So pediatric IV therapy consideration. Explain the process to the child and parent. Hand veins are painful but remain the location of choice for starting peripheral IV lines. Protecting the IV site after it has been established is critical, and sometimes we may have to splint the area. Use a pen light to illuminate veins on the back of the hand. Geriatric IV therapy considerations. Smaller catheters may be preferable unless rapid fluid replacement is needed. Use of tape can result in skin damage. Be careful when using macro drips. May lead to edema if not monitored closely. Fluid overloading is potentially serious in geriatric and pediatric patients. So you have to monitor your access, you have to monitor the patient, you have to monitor lung sounds for these patients. Locations. In choosing an IV site, consider the possibility of poor vein elasticity. Avoid small spidery veins that weave back and forth. Do not use varicose veins as they allow very little circulation. Now let's look at intraosseous infusion. Technique of administering fluids, blood, and blood products and medication into the intraosseous space of the proximal tibia, humeral head, or sternum. Long bones consist of a shaft, which is the mid portion, the ends, which is the epiphyses, and the growth plate, which is the epiphyseal plate, which is where the bone grows from. Io space comprises spongy cancellous bone of the epiphyses and the medullary cavity of the diaphysis, commonly referred to as a non-collapsible vein. So it's a vein that cannot collapse. Io sites: sternum, humerus, proximal tibia, distal tibia are common sites. To locate the humeral Io site, manipulate the patient's arm and palpate the humeral head. And sternum, humerus are common sites for the adults. The tibia is, proximal tibia is for pediatrics, distal tibia is adults. Identify the sternal Io site by palpating the sternal notch and using the Io device adhesive target as an extremely rapid flow rate. That's definitely for a shock patient. To locate the proximal tibia IO site, palpate the tibial tuberosity, then palpate 2 centimeters medial. For the distal tibia IO site, use palpation. Several products are used for placing an IO needle into the IO space. Manually inserted IO needles. So you have manually inserted, you have the power drill types. Consist of a solid boring needle, trocar, inserted through a sharp hollow needle. So the hand or manual IO needles are commonly or were commonly used in the pediatric population, infant. But most of the devices being used now is the power drill type or the injection gun, the bone injection gun. Fast devices, which is the one that is used for the sternum. There are 4 design elements which allow IO placement in the sternum: an infusion tube and subcutaneous portal, an introducer, a target/strain relief patch, and a protective dome. Can be used during cardiac arrest. So the fast is mostly used for cardiac arrest. Doesn't mean that you can't use the other access site. The fast one consists of a 14-gauge infusion tube and 10 stabilization needles. The fast responder or fast R is an updated device that has some advantages. You have the Easy IO device, features a handheld battery-powered driver with a needle attached. That's one I'm very familiar with. Used to insert an IO needle in the proximal or distal tibia of adults and children. Humeral head in adults. Different size of needles are available. The bone injection gun. It's a spring-loaded device that is used to insert an IO needle into the proximal tibia of an adult and pediatric patients. It comes in an adult size and a pediatric size. Uses safety lock as a stabilization device. The new intraosseous NIO device, spring-loaded device placed in the proximal tibia of an adult patient. The humeral head is an alternative site inserted by unlocking a safety cap. So there are numerous IO devices. Whichever one your organization uses, ensure that you are familiar with it and you are comfortable in using it in the field. To attach a fast one device, align the adhesive target on the patient and prepare to insert the device into the manubrium. Prepare the insertion site on the patient's manubrium. Position yourself behind the patient's head. Place 2 hands on the fast one device. Align the stabilization needles with the target and apply pressure until you feel the infusion tube separate from the fast one introducer. Attach IV tube into insertion tube's lower lock. Aspirate blood and particles of bone marrow to ensure proper placement. Slowly inject the IV solution to ensure proper placement of the needle. Adjust the flow rate as appropriate. Place protective dome and begin using the device. Now, potential complications of IO infusion. Extravasation occurs when an IO needle does not rest in the IO space. Risk can be reduced substantially by using the proper insertion technique. Suspect if the infusion does not run freely or if the site rapidly becomes edematous. or there is swelling. Osteomyelitis is inflammation of the bone and muscle caused by an infection. Through and through insertion occurs when an Io needle passes through both sides of the bone. Suspect a pulmonary embolism if the patient experiences acute shortness of breath, pleuritic chest pain, and cyanosis. Contraindications to Io infusion. If there's a fracture of bone, if there's a fracture of the bone intended for Io cannulation, that's a contraindication. If osteoporosis is present, that's a contraindication. If there's osteogenesis imperfecta, which is brittle bones, it's contraindicated. Bilateral knee replacement, prosthetic limb at the Io site. Mathematical principles used in pharmacology. So let's look at some mathematical principles. Fractions are expressed as a numerator over a denominator. Decimals distinguish numbers greater than 0 from numbers smaller than 0. Whole numbers appear to the left of the decimal point and fractions of numbers on the right. Percentages are part of 100 and are denoted by the percentage symbol. The metric system. Decimal system based on multiples of 10, used to measure length, volume, and weight. Meter is a basic unit of length, represented by M. Liter is a basic unit of volume, represented by L. And gram is a basic unit of weight, represented by G. The metric system commonly uses prefixes from smallest to largest: micro, milli, centi, kilo. These are some that you need to be familiar with. Now, the desired dose is the amount of medication the physician orders or protocol dictates. So, desired dose is the amount of medication required or the amount of medication that your physician orders you to administer. Volume conversion. 1 liter is equal to 1,000 milliliter. And it's a simple concept. If you're moving from a large measurement to a small measurement, you multiply by 1,000 for that conversion. So if we're moving from 1 liter to milliliter, it's a larger measurement to a smaller measurement, so we multiply that by 1,000. If we were moving from a small measurement to a large measurement, we would divide. These are simple concepts that you need to commit to memory. Weight conversion. To convert gram to milligram, multiply by 1,000. You're moving from large to small, multiply. To convert milligram to gram, you're moving from small to large, divide. Simple concepts to commit to memory. Converting pounds to kilogram, divide the patient's weight in pounds by 2.2. So that's when you're converting pounds to kilogram. If you're going to convert kilograms to pounds, you multiply by 2.2. Or you can use the rule of 10. So divide the patient's weight in pounds by 2 and then subtract 10% of that value. Now, calculating drip rates. Dimensional analysis is the easiest way to calculate drip rate. rates. Allow the comparison of seemingly unrelated items by setting up a relationship. To calculate a drip rate, you need to know which administration set to use, the length of time for the infusion, and the amount to flow. Desired dose is the amount of a medication the physician orders you to administer. Medication concentration is the total weight of a medication contained in a specific volume. Weight per millimeter equal total weight of a medication divided by total volume in millimeters. All that is saying is if you want to know the exact concentration, and the exact concentration is how much of the drug would be available in 1 ml. To find out the exact concentration, you divide the amount of drug available by the amount of ml available. So amount of drug divided by the amount of fluid available will give you the exact concentration. Important concepts. Volume to be administered. Volume to be administered is equal to the desired dose of a medication divided by the concentration on hand. So the volume to be administered has to do with the volume of the medication that you're about to administer. In order to be able to work that out, right? The exact volume to be administered is the amount of medication that would be available in 1 ml. So if I have 50% dextrose, which is 25 grams in 50 mils, and I wanted to find out what would be the exact volume of that concentration, then I would divide 25 grams by 50 mils, and that would be 0.5 grams per mil. Now, weight-based medication doses is based on the patient's weight in kilograms. 1 kilogram is equal to 2.2 pounds. Pediatric doses. Many rescuers use length-based resuscitation tapes. Field guide with tables or charts for reference. Calculations for pediatric drug dosing and medication infusions are the same as they are for adults. So it's the same type of calculation. It's just a majority of the medications that are given to the pediatric population is going to be weight-based. So it's going to be based on their weight in kilograms. We never give medication based on pounds. So once you have a pediatric patient and you know their weight in pounds, you're going to have to convert it to kilograms and work it out. Now, steps for administering by specific routes. Administering enteral medications given through some portion of the digestive or intestinal tract. Oral administration, you have capsules, time-release capsules, lozenges, pills, tablets, elixirs, emulsions, suspensions, and syrups. To give oral medication, you may use a small medicine cup, medicine dropper, teaspoon, oral syringe, nipple. Steps to administer an oral medication. Take your standard precaution. Determine the need for the medication based on the patient's presentation. Obtain a history, including any drug allergies. You should have a primary set of vital signs or baseline vital signs. Follow standing orders or contact medical control for permission, check the medication, determine the appropriate dose. If administering a pill or tablet, instruct the patient to swallow the medication with water, monitor the patient's condition, document medication given, route, time of administration, and patient response. Steps for administering by specific routes: rectal administration. If rectal administration of D50 is allowed, it should only be used as a last resort when a patient is hypoglycemic. No other route is an option. Not a common route of administration in the field, but it can definitely be used for pediatric population. Can be used for some adults as well. Steps for administering by specific routes. To administer a drug rectally, when inserting a suppository, use a water-soluble gel for lubrication. For medications in liquid form, nasopharyngeal airway or small endotracheal tube can be used as the delivery route. With a needleless syringe, gently push the medication through the tube. Once the medication has been delivered, remove and dispose of the tube. Administering parenteral medications given through any route other than the GI tract. You have subcutaneous, IM, IV, bolus, IO, sublingual, transcutaneous, transdermal, inhalation. IV administration is the most common parenteral drug route. IV, IO. Equipment: syringe come pre-packaged in color-coded packs with a needle already attached. Syringes consist of a plunger, a body or barrel, a flange, and a tip. Packaging: you have ampules, which are breakable sterile glass containers designed to carry a single dose of a medication. And you have vials, which may contain single or multiple doses. You have a rubber stopper top made of glass or plastic. You have pre-filled syringe designed for ease of use. Also single dose disposable cartridges that use a reusable syringe. Drug reconstitution, injecting sterile water from one vial into a vial that contains powdered medication, making a solution for an injection. That's how glucagon is administered. So you have to mix glucagon before you administer it. Vials determine amount and doses of medication in the vial. Once the cover is removed, it is no longer sterile. Some medications stored in vials need to be reconstituted, 2 separate vials. An example would be an Acto vial, and all it is saying is that the vial has fluid and powder which needs to be mixed before the medication is given. Pre-filled syringe or pre-filled syringes. Pre-filled syringes come in tamper-proof boxes separated into glass medication cartridge and a syringe. Subcutaneous administration. This is not a route that is used much in the pre-hospital setting, but it can be used for certain tests. It can be used for certain medication, but it's not commonly used in the pre-hospital setting anymore. Given into loose connective tissue between dermis and muscle layer, perform using a 24 to 26 gauge, 1/2 inch to 1 inch needle, and you want a 45-degree angle of insertion. That's for subcutaneous. For common sites include the upper part of the arms, anterior parts of the thigh, abdomen. Use the aseptic technique. Now, the intramuscular administration, IM, injections are made by penetrating a needle through the dermis and subcutaneous tissue into the muscle. 1.5 to 2 inch needle, 21 to 22 gauge, angle of insertion 90 degrees. Intramuscular IM administration continued. Common anatomic sites include the deltoid muscle, the vastus lateralis muscle in the thigh, rectus femoris muscle, gluteal area. Patients may have their own autoinjector. Sublingual administration, medications enter the circulatory system much faster. There is a vast network of vessels under the tongue, sublingual, and in the cheek, buccal. May be taken up in the proximal part of the GI tract without reaching the intestines. Medications come in tablet, liquid, and spray forms. Intranasal administration, which is becoming very popular. It's becoming a very popular route because a lot of medications can be given that way. Naloxone, midazolam, glucagon, a lot of fentanyl, a lot of medications can be given that route. Administered within the nose includes nasal spray for congestion or solutions to moisten the nasal mucosa, rapidly absorbed, providing a more rapid onset of action. Administration is performed with a mucosal atomizer device. Medications administered by the inhalation route, used for many medications that treat respiratory emergencies. Patient with a history of respiratory problems will usually have a metered dose inhaler, MDI. Medication administered by the MDI can be delivered through a mouthpiece or mask. So you can attach it to a spacer device. Medication administered by the inhalation route, continuing. Liquid bronchodilators may be aerosolized in a nebulizer for inhalation. Small volume nebulizers are the most commonly used method of administration of inhaled medications in the pre-hospital setting. Use a small volume nebulizer in line with an assistive device for some patients. Most manufacturers have a nebulizer that is designed to work with their device, and a nebulizer can be attached to a BVM. A nebulizer can be attached to a CPAP device, and you have your standard nebulizing device. So just remember that. So you can nebulize a patient if you're backing them with a BVM. You can nebulize a patient if they are wearing a CPAP device. Remember that. Intravenous medication administration places drug directly into the circulatory system. The fastest route of medication administration for AEMTs to administer. Medications are administered by direct injection with a needle and a syringe into an established peripheral IV line. Intravenous medication administration. Many services now use needleless systems to provide protection against needle sticks. Syringe simply screws into the injection port. Bolus, single dose given by the IV route, can be small or large quantity of a drug. Complications may arise from using the IV route, including local and systemic reactions, and we looked at that previously in the chapter. Steps to administer. Explain the procedure to the patient, assemble needed equipment, and draw up the medication. Remember, you need to confirm the dose route 3 times. Cleanse the injection port with alcohol or remove the protective cap if using the needleless system. Insert the needle into the port while holding it carefully, or screw the syringe onto the port. And remember what I stated previously, before and after giving a medication through an IV line, you need to flush the line. Pull back slightly on the syringe plunger and observe for blood return. Clean the port and insert the needle with the syringe containing the flush. Flush the saline lock and then place the needle into the sharps container. Store any unused medication properly. Monitor the patient's condition. Document details. Intraosseous medication administration. Used for critically ill or injured children and adults when IV access is difficult or impossible to obtain, and it must be used with a pressure infuser. So if you're doing IO access, you need a pressure infuser. The name might sound fancy, but just think of a pressure infuser as a BP cuff for your IV bag. So it's something that you put the IV bag in and you pump it up to create a pressure on the IV bag. A pressure infusion device should be used when infusing fluids in adults. Potential for compartment syndrome if fluid leaks outside the bone and into the osteofascial compartment. And that would be the end of this chapter, IV access and medication administration.